Hi, and welcome to Module 4, Lecture 1 for Community Health Advocacy and Social Movements. Week 7, we will identify strategies to manage aspects of patient care. So this would be assessment, planning, coordination of services, patient education and advocacy, clinical monitoring, and outlining preventive care programs to motivate individuals to improve their health status. And this might be, I'll explain it at the end, but this is sort of more of a research um, project than something we'll cover in the lecture specifically. Your readings, you had a bunch of things to read and watch this week, mostly videos. This article about care coordinators, this video is pretty long. I don't suggest watching the last 20 minutes if you don't have time because that's a question answer. But the first 35 to 40 minutes of this video, the PNHP Western Washington, is really interesting. It's about cultural care managers or navigators at Harborview Hospital in Seattle. We have chapter 4 of the book. It's a really interesting chapter. And this video just on community health workers, and I would like to cover community health workers more in this program, but that gives you a peek into what they do. We have some community health workers in this class, so we can also always ask them for more information. So let's get into managing patient care. Last lectures we were talking about primary care and prevention. So patient care, according to the Evans article, a measure being implemented for cost saving and improving the experience and outcomes of patients is the introduction of care coordinators or care navigators into the health system. Many of you wrote your chapter 3 discussion posts about care navigators or health advocates or people employed by the Black Panther Party to help Black patients navigate mainstream hospitals in a time of segregation and sort of unethical kind of race-based treatment in the healthcare system. And so you already know that health navigators are really amazing resource for community members and patients who have less or who are more vulnerable, let's say. And so who are care navigators? In the health system as we know it right now, often medical assistants, community health workers, other health providers with less clinical training um, are usually deployed as care navigators for patients. But they do also have other roles, so this is difficult sometimes because medical assistants have their regular role of intake and blood pressure and and things like that, but then they're also asked to be care navigators. Um, so the ideal patients for care coordination are safety net patients, patients on Medicare, Medicaid, because generally these will be patients who are either low income if they're on Medicaid or Medicare, they're elderly, maybe they can't hear, maybe they don't understand current health practices because they're elderly or they have, issues. So safety net patients are really um, a good candidate and for care coordination and really need it much of the time. And as well as advocates who can help them out. And at-risk patients likely to be hospitalized. So maybe they're not a safety net patient, maybe they don't have insurance, but these patients who need to avoid hospitalization or going back, like being released from hospitalization, and their care coordinator needs to make sure that they have a plan in place to recover rather than being readmitted. So, and then low resource patients. So maybe they're not safety net, but they don't have a car. So even if they have a benefit package, but they might not have enough to drive over, or maybe they have a disability, maybe they have, so people with different levels of infrastructural or maybe inner resources, maybe they have depression, anxiety, that's also considered someone at risk or who may not show up for their preventive services or for their treatments. So this is, yeah, this is a few examples, some language barriers we spoke about, and transportation, income, and multiple morbidities or complex. So maybe they're dealing with multiple conditions, depression and diabetes and heart condition and multiple things, and that might be putting people at risk for being hospitalized, but also further in need of a care coordinator. So primary care and care management, we looked at that a little bit in previous lectures. The gatekeeper model that many MCOs require. But the Evans article discusses the shift from primary care providers to health providers with less clinical training as care coordinators. And this is a global shift taking place in community health. And when I say global, that might mean an entire health network, like the entire neighbor care network or the entire whatever, but I also mean globally in the world. You saw the video about brain drain and how many doctors are being pulled out of low resource countries because they get frustrated with the infrastructure. There's no clean water, there's no electricity shorts out, and their patient might be using a treatment or a life support or something that's depending on it. So there's a lot of issues going on in low resource countries in the health sector that make doctors move. I mean, not to mention the pay, but even just the frustration of being in a hospital without adequate supplies gets to people. And so there's brain drain. So we're talking about a global shift in transferring the knowledge and skills to different types of health providers. So why might this transfer of skills and knowledge from more highly trained to less trained clinical care workers be important in community health? What have you learned from our textbook, Body and Soul, to suggest that this is a good idea? Because many of you in Chapter 3 reflection or discussion wrote about transferring skills to volunteers and lay health workers or community health workers. And why was that useful? How could it be useful in other communities? So paradigm shifts. There's two big shifts here. One is the value-based payment. So employing care coordinators means, well, the fee-for-service model, which means we give you a service, you pay for it. And by you, it could be an insurance company, but that direct exchange of fee for a service. Give a service, pay a fee. That model is challenged by care coordinators because they're not giving a direct service. They're counseling, they're helping someone out, they're talking to someone on the phone. They might be visiting their home to help them get to an appointment. So this kind of challenges that fee-for-service model. And there's a brief sort of alternative written about in the Evans article about value for service, outcomes, are patients getting better? And that might be a better way to bill if we're talking about adding care coordinators. And the other paradigm shift is job responsibilities, shifting care coordination work from doctors or the gatekeepers in MCOs and nurse practitioners, the primary care providers, to medical assistants, community health workers, nurses, and social workers. So figuring out this might be a big deal, especially for doctors who are used to doing certain things and being in charge of certain decisions or having certain relationships with their patients where the care coordinators might take that over. One, because it's less expensive, but two, because if they're a special employee designated for this purpose, it'll be much more thorough and comprehensive and in places such as in the PBS video about brain drain, care coordinators or care coordination being transferred to less trained clinical providers makes sense in the way of not having enough doctors. And even in the USA, we have a shortage of PCPs or primary care providers, let alone in areas of the world where there's brain drain and doctors are leaving because they don't have enough supplies in their hospitals. It's just a pure frustration of being in a hospital where the electricity shorts out or the clean water runs out or supplies don't come or things like that. And I mean, not to mention the pay, which is probably a lot less in low resource hospitals, in low resource countries in a hospital. So that's another reason for building the skill set of other healthcare professionals, including care coordination, and also getting designated care coordinators as well. And Dr. Carey, John Kerry's daughter, in the PBS clip, showed that her organization was increasing self-respect and respect for the profession of nursing in rural areas. Patients started listening to nurses when they themselves are trained in beautiful, well-equipped teaching hospitals with all the supplies. And though it was hard to transition from well-equipped to low resource, at least their training was correct and done in a comprehensive way. But I appreciate that Dr. Carey addressed this issue and how to shift responsibilities on other providers if there aren't enough doctors. And I believe that's a movement here too in the United States to shift responsibilities. We actually saw that in a previous lecture when there was a possibility of the overturning of Roe versus Wade. And so healthcare organizations and advocates were talking about how to transfer the privilege or the skills in performing abortions and women's health procedures to other providers and doctors. And so just figuring out how to work with the resources and the people that we have. So next, in the rest of this lecture, part 2, we'll talk about patient education and advocacy. So if you haven't seen the video yet of PNHP Western Washington, please check that out and look through the other videos, the PBS and some of the other readings as well, the Evans article. And we'll see you on part 2 of this lecture.